Hello, my name is Kathy Nelson-Piercy and I work as an obstetric physician at Guy's and St Thomas's Foundation Trust in London, and I'm going to talk through some issues to do with COVID-19 in pregnancy. Pregnant women, we know, are more susceptible to certain infections, particularly viral infections. In the H1N1 epidemic, women suffered with influenza more severely than age-matched controls, and we know that if women catch varicella, they're more prone to varicella pneumonia and can become very sick. We don't yet know if COVID-19 has the same characteristics. We do know that pregnant women who contract malaria, first of all, pregnant women are more likely to contract malaria and can become more sick when they have it. So I'm going to just talk about the confidential inquiry into maternal deaths, which we have in the UK. And this is a rolling audit of maternal deaths. All deaths are investigated and the cause identified. And most women who die in pregnancy or within 42 days of birth undergo an autopsy in this country. And these data here show you the data from the last year when sepsis was looked at in detail. And you can see on the slide that sepsis is divided into direct causes, which are the hashed bars, so that would be genital tract sepsis, and sepsis from indirect causes, which includes pneumonia and influenza. And you can see that in this triennium, sepsis was the fifth most common cause of maternal death. From that same inquiry, this was a more detailed look at causes of sepsis. The red line indicates genital tract sepsis, sepsis related to pregnancy directly. The purple bar is other indirect causes of sepsis, such as pneumonia. And the green line shows you deaths from influenza. And you can see that back in 2009 to 11, we had a peak of deaths from influenza related to the H1N1 epidemic. These have now fallen, largely due to campaigns to make sure that all pregnant women are vaccinated against flu during their pregnancy. So back to COVID-19, the clinical features will be well known to you all. Those shown with an asterisk here are those that I suffered when I had COVID-19, and we now know that the classical features include many other more non-specific features, and those of you that have had the disease will know that the headache can be really debilitating, as can the myalgia, and then this weird loss of smell and loss of taste that goes with it. As far as my experience of managing COVID-19 in pregnancy is concerned, these symptoms are no more or less likely to affect pregnant women than the non-pregnant population. In other words, pregnant women show the same clinical features as non-pregnant patients. So we know from the non-pregnant literature that about 80% of people have mild disease, 15% severe disease, and 5% requiring ITU. And this study from America by Breslin et al., looking at a small series of pregnant women with COVID-19, showed a very similar distribution, with 86% having mild disease, 9.3 severe disease, and about 4.7 requiring ITU. So very, very similar to the non-pregnant data. The graph on the right of this slide shows you this very well-known association with case fatality and age, which was shown in the influenza pandemic in 1918 and is much more obvious with the current SARS-2 COVID-19 epidemic. And that's important because pregnant women on the whole are in the flat bit of the curve between about the ages of 20 and 40. But nowadays, many women delay pregnancy, and we are seeing many women over the age of 40 becoming pregnant. So just remember that curve as we go through some subsequent. This was a study published in the New England Journal looking at universal screening of women admitted for delivery in 2 New York hospitals. So they screened over 200 women and found that 85% of them were negative, 13.5 were positive but completely asymptomatic, and 1.9% were positive and symptomatic. So this told us that pregnant women, just like non-pregnant patients, there's a large population who have asymptomatic carriage of the virus, and that, of course, is how it is able to spread so efficiently. This is a rapid literature review by Mullins et al., and I'm only showing this slide to show you that the systematic review at that stage only included 32 women, and these were all case series or case reports. And that early look at the literature suggested preterm delivery was increased at almost 50%, caesarean section 84%, and encouragingly showed no vertical transmission. But it's important to point out at this point that the Chinese especially were opting for caesarean sections in all their COVID positive women. And some of those were iatrogenic, hence leading to the high risk of preterm delivery. What is due to be published this week is the data from the UCOS study. This stands for UK Obstetric Surveillance System. This is a system whereby, including all maternity units in the UK, and COVID-19 is a notifiable disease to the UCOS system. And this publication includes 92% of all notified cases, which includes several hundred women. It will therefore be the largest series in the world. And the results show the same themes as in the non-pregnant. There's an increased proportion of Black minority ethnic women, increased proportion of women with gestational diabetes, pre-existing diabetes, hypertension, increased age, and in pregnancy that means over 35, and increased rates of obesity. All the maternal deaths during the COVID-19 pandemic will be reviewed, but sadly, the autopsies are happening less frequently. So in some cases, we may not know exactly why these women died, even though they had COVID. As far as managing COVID in pregnancy is concerned, the first thing I wanted to talk about was PPE. Most obstetric units have taken the decision to manage all patients as if they were COVID positive, and therefore we use universal precautions for everybody with a fluid-resistant mask, gloves, plastic apron, and eye protection. And that is whether they are COVID positive, COVID negative, suspected COVID, or awaiting the results of swabs. But there are certain procedures in obstetrics which would require which are aerosol generating, particularly general anaesthetic for an emergency caesarean section, where full FFP will be used. The management of suspected COVID in pregnancy is exactly the same as it is outside pregnancy. And many of you will have seen this slide before from previous presentations. The three phases of COVID, and most of the patients that I have seen with COVID-19 in pregnancy fall into stage 1. There are a few in stage 2 and only a handful, happily, who progress to stage 3 and require intubation, ventilation, ITU care. These are all chest x-rays taken from COVID positive pregnant patients, showing you the progression with the phases of the disease. How do we predict the course of COVID-19 in pregnancy? Well, we use the same tools that are used outside pregnancy, clinical assessment, particularly looking for hypoxia. We use the same blood markers. Now, I am not an advocate of D-dimers in pregnancy. They are useless as a rule-in or a rule-out test of pulmonary embolism. However, they are as useful as they are outside pregnancy in assessing the course of COVID. Please remember that both chest x-rays and CT scans, if required, are safe in pregnancy. The management of COVID patients in pregnancy is the same. They are eligible for recruiting into the recovery study, and we give them antibiotics if they have an abnormal chest x-ray. We were originally using coamoxiclav and clarithromycin, but with the advent of the recovery study, we don't use clarithromycin unless we think the risk of an atypical pneumonia is very high. I'm going to talk a little bit more about thromboprophylaxis later, but this is a phenomenally important aspect of managing pregnant patients in general and pregnant patients with COVID in particular. If for any reason low molecular weight heparin can't be used, for example, delivery is imminent, then we use thromboembolic deterrent stockings and float. Hypoxia is very important, just as it is outside pregnancy, and we have spent a long time educating midwives and obstetricians about the importance of hypoxia as a marker of disease severity. Put simply, the more oxygen somebody needs, the more unwell they are with COVID. But remember that young women, like young men, compensate well, and so we have seen several cases of sudden deterioration because women are able to tolerate the hypoxia better than older patients. I said I'd come back to the thromboembolic risk. These are recommendations taken from the Corona Infection in Pregnancy Guideline published by the Royal College of Obstetricians and Gynecologists with the Royal College of Midwives. This is a weekly updated publication, and this quote is taken from the version 7, which included specific recommendations about thromboprophylaxis. These are also drawn from the RCOG Green Top guideline that is used throughout the UK on thromboprophylaxis in pregnancy. And essentially what it says that any pregnant woman admitted with COVID requires thromboprophylaxis while she's in hospital, unless you think birth is imminent, because if you give the low molecular weight heparin, that would preclude the use of regional anaesthesia. And if she then goes home, she requires 10 days of prophylaxis to take at home after discharge from hospital. Similarly, one really important point that I want to make is that it's really vital that when assessing a pregnant woman who is breathless or who has a fever, that you don't just think this is COVID and that other causes are considered. And throughout the last 6 weeks, I have seen choriamnitis called COVID, I've seen asthma called COVID, and I've seen pulmonary edema and heart failure called COVID. So avoid COVID centricity. And I'm sure you're well aware of this in acute and general medicine. And it's the same in pregnancy. There are many causes of breathlessness, many causes of fever, and I would refer you all to the Acute Care Toolkit published by the Royal College of Physicians last year, together with the Society of Acute Medicine, which lists red flags for different common presentations in pregnancy. And this is as relevant in COVID as it is in any other time. Pregnant women can have pneumothoraces, they can have pulmonary emboli, they can develop heart failure, and they can develop sepsis from other causes. And it's really important that these aren't forgotten about and it isn't assumed that everyone who presents who's unwell has COVID. Just to finish up, a few practical considerations on the labour ward. As I've said already, we manage all women as if they are COVID with regard to PPE. When we had several COVID positive pregnant patients, we corralled them at one end of the labour ward, and we tried to ensure that midwives were managing either COVID positive or negative, but not both. And we had a second layer, a second team, if you like, a COVID team that included, excuse me, a second consultant obstetrician, obstetric anaesthetist, and members of the obstetric medicine team. And lastly, but most importantly, we had very clear guidelines for escalation to the critical care outreach team. Remember that many midwives are not nurse trained, they're direct entry, and many obstetricians have not done medicine. Therefore, we needed very clear guidelines to help the obstetricians know when to refer to the medics and to the critical care. And this is the table taken from our trust guideline about onward referral. And you can see it relies very much on hypoxia. So depending on the level of hypoxia, that determines whether you escalate to the COVID team and then subsequently to the critical care outreach team. And importantly for the obstetricians is if you think you're going to have to intubate somebody, you need to start thinking about giving the mother steroids to mature the baby's lungs and magnesium sulfate for neuroprotection. This slide summarises the COVID positive patients that we've had at Guy's and St Thomas's. 27 in total over 5 weeks. We haven't had any for the last week. 11 were postnatal. The rest were antenatal. 3 were admitted to ITU. 1 woman was an in utero transfer who required ECMO. All 3 patients admitted to ITU have been stepped down. 2 were admitted postnatally. 1 was admitted antenatally. The one who was admitted antenatally was not delivered. Of those who presented antenatally, the vast majority were in the 3rd trimester. So that's reassuring given that women in the 3rd trimester of pregnancy were advised to shield, if you remember. Like the UCOS data and like the non-pregnant data, we saw an overrepresentation of BME women, women with diabetes, women with hypertension and obese women. And both of the antenatal women who required oxygen were delivered, and both these women were over 40 years old. The key messages from this talk are that we found it incredibly important to reassure and educate midwives and to work as teams, particularly about the importance of hypoxia. I really want to stress this important issue of not forgetting other obstetric and medical diagnoses. Don't forget thromboprophylaxis during admission and after discharge, the importance of escalation and knowing who to escalate to, and really for any obstetricians listening to this, the decisions about when to deliver a woman who has a viable baby after 24 weeks need to be individualized. And one person should not make that decision alone. It should be made as a team. But what I would say is that once the woman requires ventilation, intubation and ventilation, then that is usually an indication for delivery.